We'll be breaking down all major concepts covered on the exam. When studying the central nervous system, it really helps to think of it as like the ultimate panic room.
Oh, I like that analogy. It's this incredibly secure, completely closed compartment, right?
Exactly. It is entirely sealed off from the rest of the body by thick bone and these heavily guarded membranes. I mean, it's designed to keep everything dangerous on the outside.
But there is a terrifying flip side to that design, isn't there?
Yeah, there really is. Because if a microscopic invader actually manages to breach those defenses, well, that panic room suddenly becomes a trap.
Right, because the very walls meant to protect the brain end up locking the danger inside.
And the pressure just has nowhere to go.
Which is precisely why infections in this space escalate so rapidly. I mean, they turn into medical emergencies almost instantly. The central nervous system has, very little room for error.
And even less room for inflammation. So, I'm Harvey.
And I'm Donna. We are your dedicated MCCQE reviewers.
And our whole goal is to help you, the Canadian medical student, master the exam review process.
Today's deep dive is sourced directly from reliable StatPearls articles covering section S08 Neurology.
We are tackling infections of the nervous system. So specifically, we're looking at meningitis, herpes simplex encephalitis, and brain abscesses.
But before we get into the clinical vignettes, we do need a quick but mandatory disclaimer.
Right, of course. This deep dive is purely for medical education purposes. It is not medical advice. And any clinical decisions in the real world must involve a qualified healthcare provider.
All right, so let's get clinical.
Yes, let's do it. To really understand these pathologies, I think we need to trace the journey of an infection from the outside in.
That makes sense, starting with the defenses.
Right, because before a pathogen can even touch the brain tissue itself, it has to get through the three membranes wrapping the brain and spinal cord.
The dura, the arachnoid, and the pia mater.
Exactly. And when those surface wrappings get inflamed, that's when you have meningitis.
I actually want to pause right there because I know you are probably confusing the presentations of meningitis and encephalitis right now.
Oh, yeah. It is incredibly common when you're staring down these exam vignettes.
You really have to clearly separate them in your mind. Meningitis is the inflammation of the meninges, the surface wrapping.
Right.
Whereas encephalitis is the inflammation of the brain parenchyma itself, like the actual brain tissue.
They can overlap, sure, but clinically, you need to identify which one is driving the primary presentation.
Exactly. So let's picture a patient walking into the ER to, anchor this.
Okay, imagine a 22-year-old college student. They come in clutching their head, they're wearing sunglasses in a dimly lit room, and they absolutely refuse to look down at their phone.
That gives us the classic adult triad for meningitis, right?
Yes, fever, severe headache with neck stiffness, and photophobia.
And you'll also see those classic meningeal irritation signs on the physical exam.
Like if you flex their neck, their hips and knees spontaneously flex. That's Brzezinski's sign.
Or if you extend their knee while the hip is flexed, it causes severe pain.
Right, Koenig's sign.
But, that is just the textbook adult presentation. The MCCQE loves to test your knowledge of how presentations and pathogens change based on patient demographic.
Oh, for sure. If you take that exact same infection and put it in a neonate, say a 3-week-old infant, you are not going to see any of those classic signs.
Not a single one, because their nervous system is totally underdeveloped.
Right. So if I'm reading a vignette about a neonate, I am not looking for a stiff neck.
What are you looking for then?
I'm looking for incredibly subtle, non-specific clues. I mean, they might not even have a fever. They could actually present with hypothermia.
Wow, yeah, hypothermia. Or you might just see poor feeding, extreme irritability, lethargy, or a bulging fontanelle because their skull plates haven't fused yet.
Exactly. The threshold for suspecting meningitis in a lethargic neonate should be practically on the floor.
And the bugs causing it are entirely different too, right?
Totally. In that neonate, up to 1 month old, the invaders are organisms acquired during birth, primarily group B, Streptococcus, and E. coli.
But as the patient grows into a standard, healthy adult, like your 22-year-old college student, the threat profile shifts.
Right. It shifts to Streptococcus pneumonia and Neisseria meningititis.
Now here's a massive exam trap that trips up a lot of students.
Let's hear it.
What happens when the patient crosses the age of 50 or, if they're immunocompromised? Let's say a 65-year-old patient comes in with those meningeal signs.
Well, we know the standard adult empiric therapy is intravenous ceftriaxone and vancomycin.
But if I just give those two drugs to a 65-year-old, I've missed something critical.
You've missed Listeria monocytogenes.
Exactly. As we age, our cell-mediated immunity, specifically our P cell function, it begins to decline naturally.
And this immunosenescence makes older adults, along with neonates and the immunocompromised, highly susceptible to Listeria.
And here is the actual mechanism you need to understand. Listeria is intrinsically resistant to all cephalosporins.
Wait, all of them?
All of them. So that ceftriaxone you're pumping into the patient, it does absolutely nothing to stop a Listeria infection.
That makes a lot of sense. If you understand that cephalosporins biochemically cannot bind to Listeria's penicillin-binding proteins, you don't need to rote memorize the treatment rule.
Exactly. You inherently know you have to add a different class of drug.
Which is why we add intravenous ampicillin to the regimen for anyone over 50.
If you don't select the option with ampicillin on the exam for that demographic, you lose the points.
Absolutely. And if the vignette reveals the pathogen is N. meningitis or Haemophilus influenza type B, don't forget the people who brought the patient to the ER.
Right. Close contacts require immediate chemoprophylaxis to eradicate nasopharyngeal carriage.
You'll typically prescribe rifampin, ciprofloxacin, or ceftriaxone for them.
Okay, let's back up to the diagnosis phase for a second.
Sure.
We suspect meningitis, and we know we need cerebrospinal fluid, or CSF, via a lumbar puncture to definitively prove it and culture the bug.
Right, but before you do that LP, you need to start those empiric antibiotics we just talked about.
Always. I always think of this like a house fire.
Oh, that's a good way to look at it.
Yeah, like if you pull up to a blazing house, you don't stand there on the lawn waiting for the arson investigator to arrive and tell you exactly how the fire started before you turn on the hoses.
No, you put out the fire immediately to save the structure.
That analogy is the golden rule for the MCCQE. You never delay empiric antibiotics to wait for a lumbar puncture.
And you certainly never delay them to wait for a CT scan. You save the brain first, then you investigate.
Let's actually unpack that CT scan aspect, because the CT before LP dilemma is probably one of the most highly tested safety concepts in all of neurology.
Definitely. If we're worried about doing an LP, I'm assuming we're looking for clinical signs that the brain is already under massive pressure, right?
Right, because if the pressure inside the skull is drastically high and we puncture the lower spine to drain fluid, we essentially create a low-pressure sink.
And fluid follows the pressure gradient.
Precisely. If the intracranial pressure is massive and you suddenly release pressure at the bottom of the spinal canal, the brain will instantly herniate downward.
Through the foramen magnum at the base of the skull, just crushing the brainstem.
It is rapidly fatal.
So we only order a head CT before the lumbar puncture if we see red flags for impending herniation.
Yes.
What are those clinical red flags they should look for in the vignette?
You are looking for a severely altered mental status, new focal neurologic deficits like hemiparesis, non-reactive pupils, or bradycardia combined with hypertension, which is the Cushing reflex.
If you see any of those, you must get the CT first to rule out a massive shift in brain tissue.
But again, going back to your fire analogy, if you have to delay the LP to transport the patient to the CT scanner, you hang the IV antibiotics first.
Save the brain, then investigate. Okay, so let's say there were no red flags. We did the LP safely.
Good.
I know you're probably staring at these lab values in your practice questions, and they all just blur together.
They really do.
But if we pull back and think about what is actually happening in that spinal fluid, bacteria are living organisms that need energy to rapidly divide.
Right.
So they must be aggressively consuming the glucose in the CSF.
That is exactly the clinical dividing line you need to look for. Bacterial meningitis is going to show a highly elevated white blood cell count with a massive neutrophil predominance.
And because those bacteria are eating all the sugar, the glucose level will be incredibly low.
While the protein will be sky high from all the inflammatory debris.
And what about viral meningitis? Because viruses don't consume glucose in the same way.
Correct. Viral meningitis shows a lymphocyte predominance and, crucially, a normal glucose level.
Okay, that brings us perfectly to our next major topic. We've seen what happens when an infection spreads across the surface membranes.
The meningitis.
Right. But what happens if a viral infection doesn't just inflame the wrapping, but actually invades the panic room itself?
The brain parenchyma.
Yes, this is herpes simplex encephalitis, or HSE.
And this is where the clinical picture gets truly destructive. HSE is the most common cause of life-threatening sporadic encephalitis worldwide.
In adults, this is almost exclusively driven by herpes simplex virus type 1, or HSV1.
Note that HSV-2 is the primary culprit in neonates who acquire it during delivery, but for adults, you are looking at HSV-1.
The cold sore virus.
Mm.
It's just wild to think about how something so common gets into the brain.
It really is. It doesn't just float through the blood.
No, it actually hijacks our own wiring and travels retrogradely.
Right, so the virus infects the mucosal surfaces of the mouth or nose, gets taken up by the axon terminals of the olfactory or trigeminal nerves, and literally travels backward along the nerve.
Straight into the central nervous system.
And once it gets inside, it has a very specific geographic target. It aggressively attacks the medial temporal lobes and the adjacent limbic system.
Which perfectly explains the clinical shift in the patient's presentation. You move from the meningeal surface symptoms, the headache and stiff neck, into profound, actual brain tissue dysfunction.
Right. In the vignette, you'll see a patient with altered mentation lasting more than 24 hours.
But because the virus is specifically destroying the temporal lobe, which handles memory, language, and emotion, you see very specific cognitive and behavioral changes.
Aphasia, profound memory loss, and severe personality changes.
You might even see a very specific high-yield psychiatric presentation called Kluver-Bucy syndrome.
Yes. Because the amygdala in the temporal lobe is damaged, patients lose their normal fear and restraint.
Right, to give that some vivid context, this isn't just mild confusion. This is a patient in the ER who might be demonstrating hypersexuality towards the staff.
Or severe hyperorality, literally trying to put inappropriate objects like the hospital TV remote or medical instruments into their mouth.
And these behavioral changes are often misdiagnosed as an acute psychiatric break. But if you see a fever, a headache, and these bizarre temporal lobe signs, you must suspect HSE.
So you do an LP. We established that viral meningitis usually shows lymphocytes and normal glucose.
HSE looks similar, but with a critical addition.
Right. Because HSV-1 causes severe hemorrhagic necrosis, literally bleeding, and tissue death in the temporal lobes, you will frequently see elevated red blood cells in the CSF.
So the red blood cells in the spinal fluid are essentially a footprint of the temporal lobe hemorrhage.
Exactly.
If I see an infectious viral CSF profile, but it has a bunch of RBCs, and the vignette specifies it wasn't a traumatic tap from a clumsy needle insertion, I need to be thinking herpes encephalitis.
Precisely. To confirm it, you send that CSF for an HSV PCR test.
But here is a major MCCQE trap. Let's say it's day 2 of the patient's symptoms. The PCR comes back negative.
But clinically, the patient is still confused, febrile, and has temporal lobe signs. What do?
This feels like a moment where you have to trust your clinical gut over the lab test. A false negative HSV PCR is very common in the first 72 hours of the illness, right?
Yes, exactly. The viral load in the CSF might just be too low to detect that early. Or ironically, all those red blood cells and protein from the hemorrhage can actually interfere with the PCR assay's chemical reaction.
Wow, okay. So if your clinical suspicion is high, you never stop treatment based on one early negative test.
Never. You keep the patient on IV acyclovir and repeat the lumbar puncture in 3 to 7 days.
Now let me push back a bit here on the imaging side.
Okay, go ahead.
If a patient comes into the ER, they are profoundly confused, maybe they just had a focal seizure, my first instinct to rule out a stroke or a bleed is to roll them immediately to the CT scanner.
Sure, that makes sense logically.
So why are the guidelines saying a CT isn't good enough for an acute HSE presentation?
Because a CT scan relies on tissue density changes, and those take time to develop. You can scan an HSE patient on day 1 or day 2 of their symptoms, and the CT might look completely normal.
Ah, I see.
The structural damage often doesn't show up on a CT for 3 to 4 days. By the time you see the hypodensity on a CT, the temporal lobe is already irreversibly destroyed.
So MRI is the absolute gold standard here because it detects the fluid shifts from the inflammation much earlier.
Exactly. You are looking for hyperintensity bright white signals on T2 or FLA-R sequences, specifically in the medial temporal lobes.
And the exam might also throw a classic EEG finding at you to confirm the temporal lobe irritability.
Yes, PLEDs. Periodic lateralizing epileptiform discharges.
Okay.
These are repetitive, spiky waves on the EEG localized right over the temporal lobes. If a vignette gives you PLEDs plus a fever and confusion, you are treating for HSV.
And that treatment is intravenous acyclovir, 10 milligrams per kilogram, every 8 hours.
It is an absolute lifesaver.
It is, but it has a very specific mechanism of toxicity that students always seem to forget.
A cyclover is metabolized and excreted by the kidneys, but it has poor solubility.
Right.
If the urine is highly concentrated, the acyclover will actually precipitate and form sharp crystals inside the renal tubule.
Ouch, causing acute crystal-induced nephropathy and kidney failure.
So to prevent that, you don't just hang the antiviral. You have to ensure aggressive intravenous hydration while the patient is on the medication to keep the urine dilute and flush the drug through the kidneys.
Okay, so we clear the virus, we protect the kidneys, and the patient survives.
But the story doesn't always end there. The sources outline a fascinating and honestly terrifying post-HSE complication.
Autoimmune encephalitis.
Yes. In up to 27% of patients, within 1 to 3 months of fully recovering from the viral infection, they suddenly deteriorate again.
Their mental status drops, they start having seizures. But this time, if you do an LP, the CSF is completely negative for the herpes virus.
Exactly.
Let me see if I have this mechanism straight. The initial viral infection caused so much explosive cellular destruction in the brain that neural antigens, specific proteins inside the brain cells, that are normally completely hidden from the body's immune system spilled out.
Yes, exactly.
And the immune system suddenly sees these foreign-looking proteins, creates antibodies against them, and then mounts a massive attack on the brain tissue long after the virus is gone.
That is beautifully explained. Specifically, the immune system creates anti-NMDR antibodies. And this presents with very distinct clinical features. Choreothetosis, which are these continuous, writhing, involuntary movements of the limbs and face, along with severe psychiatric symptoms and refractory seizures.
It's a critical complication to keep in the back of your mind for a vignette describing a patient who was recently treated for encephalitis and returns weeks later with new movement disorders.
Absolutely.
Okay, so we've covered diffuse surface inflammation with meningitis and diffuse tissue invasion with encephalitis. Let's shift gears.
Let's do it.
What happens if the brain's immune response actually manages to trap the invading bacteria in one place? It walls the infection off entirely, creating a localized, space-occupying lesion.
A ticking time bomb. This is the brain abscess.
Right. It is an area of liquefactive necrosis,
Right.
literally liquid, dead tissue in pus, tightly enclosed by a distinct collagen capsule.
How did these bacteria even get deep into the brain to form an abscess in the first place?
Well, there are two main routes of entry: direct contiguous spread or hematogenous spread.
Contiguous meaning it traveled from right next door.
Exactly. For example, a severe middle ear infection, like otitis media, can literally erode through the temporal bone and form an abscess in the inferior temporal lobe or the cerebellum.
And dental infections or frontal sinusitis tend to spread directly upward into the frontal lobes.
And then hematogenous spread means it traveled through the bloodstream from a distant site.
Now, here is a massive pediatric fact you need to highlight in your notes. What is the most common cause of brain abscesses in children?
Cyanotic congenital heart disease. It accounts for over 60% of brain abscess cases in the pediatric population.
Again, don't just memorize the fact, understand the why.
Yeah, think of the pulmonary capillary bed in the lungs as a massive biological water filtration plant.
Normally, all venous blood goes through the lungs, and the immune cells there filter out and destroy any random bacteria floating in the bloodstream.
But if a child has a right-to-left shunt in their heart, like tetralogy of Fallot, the blood completely bypasses the lungs. The filtration plant is skipped.
Those bacteria go straight into the systemic circulation, travel up to the brain, and set up camp.
So if the vignette describes a 5-year-old with a history of turning blue during feeding, who now has a severe headache and a focal weakness in one arm, it is a brain abscess until proven otherwise.
And speaking of that presentation, the textbooks often list a classic triad for a brain abscess.
EVER, severe headache, and a focal neurologic deficit.
But be very careful on the exam because fewer than 50% of patients actually are present with all three.
Wait, really? Fewer than half?
Yes. The abscess capsule often prevents a systemic fever response. The manifestations can be incredibly nonspecific, just a dull headache and mild confusion, which notoriously delays the diagnosis.
So how do we find it? We obviously need advanced imaging.
MRI with contrast is your best friend here. A classic mature abscess will show a very distinct, smooth, ring-enhancing lesion.
Right, because the contrast dye leaks out of the newly formed blood vessels in the capsule, creating that bright ring. But wait, a necrotic brain tumor, like a glioblastoma, can also look exactly like a ring-enhancing lesion on a standard contrast MRI. How do you tell the difference between a pocket of pus and a dying tumor without cutting the patient's skull open?
You look at a specific MRI sequence called diffusion-weighted imaging, or DWI. This is an incredibly high-yield concept.
Okay, break that down for us.
DWI measures how easily microscopic water molecules can move around within a tissue. Inside a necrotic tumor, the center is mostly just dead, watery tissue fluid, so water molecules can move around freely.
But inside an abscess, that center isn't just water. It is packed full of thick, highly viscous pus, dead white blood cells, and dense inflammatory debris.
The water molecules physically cannot move. Their diffusion is restricted.
Exactly. Restricted diffusion shows up as extremely bright or hyperintense on a DWI scan.
So if you see a ring-enhancing lesion that lights up bright on DWI, you are looking at an abscess, not a tumor.
Okay, so we found the abscess on MRI. We know it's a bacterial infection, so we need to know exactly what bug we are dealing with to tailor our long-term antibiotics.
Right.
In meningitis, we did a lumbar puncture to get a fluid culture. So since the patient is already on the table, can we just do a quick LP here, grab some CSF, and see what grows?
Absolutely, unequivocally no. If you select lumbar puncture as the next step for a patient with a known brain abscess on the MCCQE, you will fail the question instantly.
It is an absolute contraindication. Let's reinforce why, going back to the physics we discussed earlier.
An abscess is a massive space-occupying lesion. It is taking up room that doesn't exist, pushing the healthy brain tissue aside, and drastically increasing the intracranial pressure.
If you stick needle in the lower spine, you recreate that exact same fatal low-pressure sink.
The brain will follow the pressure gradient, herniate downward, and crush the brainstem.
So how do we safely get a sample to culture if we can't tap the spine?
You have to go directly to the source. The diagnosis and culture are obtained via stereotactic CT-guided aspiration.
So a neurosurgeon drills a small burr hole in the skull and guides a needle directly into the abscess cavity to drain the pus.
And once we have the culture, management is usually a prolonged course of high-dose IV antibiotics, typically for 4 to 8 weeks, because it is very hard for drugs to penetrate that thick capsule.
And if the abscess is larger than 2.5 centimeters, it usually requires surgical excision or ongoing serial aspiration.
Right. And a quick high-yield note on steroids. They are highly controversial in brain abscess management.
Really? Why is that?
You strictly reserve them for patients who have severe life-threatening cerebral edema and mass effect shifting the midline of the brain. You do not use steroids routinely because they suppress the immune system.
And that can actually prevent the formation of that protective collagen capsule, allowing the infection to spread further.
Exactly.
Incredible. We've gone from the surface meninges to the viral destruction of the temporal lobes, all the way to a walled-off, highly pressurized abscess.
A lot of ground to cover.
It is. As we wrap up this clinical deep dive, if there is one overarching theme tying all three of these pathologies together for your exam preparation, it is the fundamental question of to LP or not to LP.
That is the perfect summary. The core MCCQE mindset isn't just about diagnosing the disease, it's about knowing the safest, immediate next step.
Right. For meningitis, you want the LP, but you cannot delay antibiotics for it, and you must check for herniation signs first.
For encephalitis, you need the LP for the PCR, but you have to know when to repeat it if it's falsely negative.
And for a brain abscess, the LP is an absolute fatal contraindication. Recognize the presentation, understand the underlying physics of the skull, and above all, do no iatrogenic harm.
Do no harm. It is the foundation of everything we do.
Now, before we sign off, there's a fascinating cutting-edge connection tucked away in the source material regarding herpes simplex encephalitis that is, really worth pondering.
Yes, the potential link to Alzheimer's disease. It's a very compelling hypothesis in the neurology community right now.
Think about the pathophysiology we just discussed. HSV1 specifically targets and chronically damages the medial temporal lobes and the basal forebrain.
Those are the exact same anatomic regions of the brain that undergo severe degradation in Alzheimer's disease.
Furthermore, both conditions result in the exact same profound anterograde memory loss.
And researchers have noted a statistically significant correlation between the APOE4 gene, which we all know is a major established risk factor for Alzheimer's, and higher loads of the latent HSV genome in the brain.
The thought is that patients who carry the APOE4 allele and have a latent HSV infection might be highly susceptible to developing Alzheimer's later in life.
Because their immune system struggles to keep the dormant virus in check.
It really makes you wonder, if that cold sore virus breaches the defenses early in life and sets up a permanent latent camp inside your temporal lobe, What kind of slow, quiet, microscopic damage is it doing over the course of 4 or 5 decades?
It's a wild thought to ponder as you review your neurology notes tonight.
Keep studying hard, trust your training, and we'll see you on the next deep dive.